So sorry for the delay. We'll start with the first speaker. The first speaker will be Dr. Rajesh Gudipatti. He will be speaking on a rare combination of TGA and TAPVC. Dr. Rajesh, please.
Yeah. Good morning, everyone. I'm Dr. Rajesh, second year DNB Pediatric Cardiology from Star Hospitals, Hyderabad. This presentation is regarding a case reporting of rare combination of two cyanotic congenital heart diseases, that is TGA and TAPVC. We all know that in congenital heart diseases, a combination of any structural defects is possible, and a few combinations are very common, and we all know the hemodynamics of those common combinations. But this is a very rare combination, and many of us may not be aware of the hemodynamics of this rare combination. So I want to briefly discuss the hemodynamics in this presentation. So TGA, which is relatively common than the TAPVC, with incidence of 20 to 33 per 1 lakh live births, and TAPVC 6 per 1 lakh live births. And combination is very rare, and very few cases have been reported in the literature. And as I told, one pathology alters the hemodynamics of the other. So we have two such cases. That case 1, which is 2-month-old, weighing 3.8 kg, presented with respiratory distress and failure to thrive. And on examination, the important finding was no clinical cyanosis and saturations were 87. So, and 2D echo revealed a DTGA supracardiac obstructive TAPVC with large VSD. Another case, 5-day-old neonate, presented with almost similar presentation. And again, there is no clinical cyanosis, saturations were about 89. And 2D echo revealed DTGA infradiaphragmatic TAPVC with large VSD and tiny PDA. So echo images of the case 1. So the 4-chamber view showing dilated right heart and common chamber posteriorly, LV on the left side and RV on the right side. So this is PA arising from the LV, which is branching. So we can see a vertical vein draining into the innominate vein. This is a right vertical vein draining into the innominate vein, which is obstructed. So for the confirmation of the diagnosis, we did CT angio, which confirmed our 2D echo diagnosis, that is DTGA supracardiac TAPVC. We can see dilated SVC. We can see dilated SVC here. Dilated SVC. And next, these are the echo images of the second case, which is, again there is dilated heart, common chamber we can see, and this is the descending vertical vein, which is obstructed, draining into the portal vein. So we can see PA from the LV and aorta from the RV. So both of the cases underwent complete repair, that is arterial switch operation and TAPVC repair. First case at the age of 3 months of age, and post-operative case of first one was smooth, no any post-operative complications, discharged on post-op day. And recent follow-up, that is 1.5 year post-op period, baby is doing well with no complications, long-term complications, with appropriate weight gain and development. And case 2 underwent surgery at day of life 24. Baby had culture positive sepsis in the immediate post-operative period. So for the completion of the antibiotic course, hospital stay was the 14 days. And follow-up period at the 10 months post-operative period, he had PH and he's on sildenafil and bosentan. Otherwise, appropriate weight gain and development was normal. So these are some intra-op images of the case 1. We can see the anteriorly aorta and posteriorly pulmonary artery. And in this, we can see that dilated SVC on the right side. This is dilated SVC. Dilated SVC. Yeah, that is the dilated SVC. So these post-operative echo images of the case 2, that wide open anastomotic site. and there is laminar flow across the great vessels, both aorta and the pulmonary artery. So a very few cases, about 10 cases that have been reported in the literature, 4 cases with intact IVS and 6 cases with VSD. And all those cases that have been reported before 2000 underwent atrial switch operation along with the TAPVC repair, because at that time the thinking was like that, because of decrease in both the preload and afterload of the LV may not be well developed and it cannot tolerate the systemic aorta. So they decided to go for atrial switch operation. But those cases that have been reported after 2000, all the babies underwent complete repair, that is arterial switch operation and the TAPVC repair. And all those cases that have been reported are doing post-operatively, immediate post-op period as well as long-term period, are doing well with appropriate weight gain and development. So as I told, hemodynamics would be different, completely different from that of that isolated TG or TAPVC. Because of the drainage of the pulmonary venous return to the right side, which is systemic side in this case, so there may be relatively high saturations. And also there is pulmonary decreased pulmonary overload because pulmonary veins are draining into the right side. So the clinical picture of TGA completely changes if it is associated with the TAPVC. Because of the relatively high saturations, as I told, patient may present lately. And if there is intact IVS, by that time the LV may be regressed. So it is a very important hemodynamic change when it is associated with the TAPVC. So in a case of TGA, we should suspect TAPVC when there is early LV mass regression and neonates presenting with high saturations with an inadequate mixing communication. And again, after assessing the LV properly, whether it can tolerate aorta or not, we can safely proceed for the arterial switch operation, complete repair along with the TAPVC. So, thank you. Thanks. Yes. Yes. On the right side, yes. Sir, if in the case of intact IVS, it is not true in all the cases, but in case of intact IVS, supposedly maybe there may be early LV regression. So main thing is we have to detect the TAPVC if there is early LV mass regression. So whenever there is LV mass regression, anyhow we have to do the surgery earlier. Yeah, maybe there is. Yeah, because both there is also decrease in the preload in this condition along with the decrease of the afterload. So the school of thinking was like regression may be earlier than the only isolated TG and intact IVS. Yeah, actually only post-operative special concentration was that chest closure was done on the second post-operative, on the next day of the post-operative period, because to repair the TAPVC, VSD and TGA, pulmonary bypass time was very long. So maybe with, because of the risk of bleeding, so surgeons kept open the chest for 1 day, and after confirming that bleeding was not there, then they closed the chest after 1 day of the surgery. And other than that, I think there no any other special intervention. Yes, sir. Yeah, day after 24. Yeah. Yeah, actually diagnosis was made on day 5, sir, but he had sepsis, bad sepsis. So he was admitted in the hospital, treated for that, and then he was, sir? Yeah.
TGA with total pulmonary venous drainage, suppose intact IVS or only PFO, how the patient can survive or is the depression present day? Because on the left side, pulmonary venous drainage is on the right side. No blood is going onto the layer or in the LV. Once you go to the lungs and the exchange will be there. There should be.
We had VSDs in both the cases.
The effective pulmonary blood flow is only the PFO.
That's the restricted. That should be emergency.
Yes. In that sense, can you explain?
Sir, in our two cases, there is a VSD, sir, for the mixture of the blood. VSD was there in our two cases. Intact IVS? Sir. Second case, both the cases we have VSD, sir. Yeah.
That's how it survived with a good effect.
Yeah.
Suppose one post-op was sir asked, suppose LLI, suppose when it's an early regression of the LV,
Yes, sir.
so then the post-op you have to see for the LA pressures also and then you have to decide for the further plan also. Suppose
Yeah.
here to the VSD is that your LV is not regressed. So it's
Not
maintained.
regressed, yes, sir.
That's the always is
Yeah.
But otherwise low cardiac output in that you have to do as early as possible.
Yeah, as early as possible, and we have to get ready for the post-operative mechanical supports.
Yes, sir. Because the LA pressures they were unable to maintain.
Yes, sir.
And then the cardiac output will be.
Yeah.
So here both cases are in VSD. that's
VSD,
why the
yes, sir.
LV
That's why they were,
is not
yeah, yeah. Lucky,
But it's still
unfortunately.
taking a risk of TAPVC waiting for 24 days is a little because suddenly they will die.
Yeah.
Sometimes in our practice case, sometimes when you are waiting for TAPVC, suddenly they will arrest you, don't have anything to revive that also.
Yeah.
So
But-
it's pretty long time. It's a good case, good case.
Thank you, sir.
So we'll call the next presenter. He is from Apollo Chennai Hospitals. Pre-stenting RVOT, is this the future strategy for PPVI?
Good morning, one and all. I'm Dr. Rajavijender from Apollo Children's Hospital, Chennai, and we hereby publish our data. In the last 3 years, what we are doing in our center is a single center experience. Whether pre-stenting of RVOT is a future strategy for percutaneous pulmonary valve implantation. Background, as we all know, post-tetralogy of fallow surgical cases having progressive pulmonary regurgitation about 80%, and RV dilatation we are seeing in the most of the cases, and about 20% are having large RVOTs and RVOT aneurysms, and we also see the RVOT obstruction. These causes the symptoms in the children, and these are the main indications for the future pulmonary valve implantation, whether it is surgical or transcatheter. Currently available valves, as we all know, the diameters ranging from the 18 to 22 for the Melody valve, and the advanced valve from the 22, 23, 26 and 29. And the Merrill valve also the same, similar to the Edward Sapiens valve. We are having the diameters of 22, 23 and 29. These are the balloon expandable valves. And the main thing is whether it is a huge RVOT, what we are going to do. In the cases of when it is huge RVOT and the RVOT diameters are very large and not accommodating those valves which we discussed earlier. We are having one valve, venous P valve which having largest diameter of 36 mm. So what is the disadvantage is when the huge RVOT, when we keep these valves, there is a loss of energy by eddy currents. So this is one of the disadvantage. Now here comes the research question. Is RVOT stenting a safe procedure? By answering this question, we want to see whether pre-stenting RVOT can prevent RVOT dilatation, thus defining the landing zone for future percutaneous pulmonary valve implantation. We are having our center experience of last around 3 years. It's a retrospective study. The study population we include are post-tetralogy of Fallot surgical cases of various surgical approaches, and those who underwent the stenting of RVOT depending on the ages based on the dilatation, the RVOT or stenosis in the cath, that is more than 2/3 of the systemic. Procedure. Initially we have done angio in RIO 30, cranial 30 and lateral views, and we measured the RVOT gradients, and balloon dilatation was done to assess the coronaries and to assess the distensibility of RVOT and to make the proper stent measurements. The stent was implanted 2 to 4 mm more than the narrowest point of the balloon. Patient selection. We have selected 7 patients. 6 of them had RVOT gradients more than 2/3 systemic in the cath measurement, and 1 patient which having progressive RVOT dilatation. So we have electively stented this patient. For stenosed RVOT, we use CP stent because it has a high radial strength. For dilated RVOT, we are using Andra-XL stents. Results. The primary age at the primary surgical repair was mean was 2.5 years, range from the 7 months to 4 years, and surgeries, various surgeries, VSD plus RV2 PA conduit 2, subannular patch with open pulmonary valvotomy 2, sub and supraannular patch 1, transannular patch 2. And the mean age of stenting was 9 years, which was range from 2 to 25 years. RVOT gradient mean was 77 and minimum was 35, and stenting time from the surgery mean was 3.5 years. This is a bar diagram showing the various gap between age of surgery and age of. The average duration was 3.5 years and minimum duration was 3 months, and smallest age we underwent stunting was 2 years. Here you can see, this is a 1 patient we have done electively stunting to prevent the further RVOT dilatation, even though we are not seeing much gradient. And I already told we have done CP stent in 6 and Andra-XL stent in 1. The follow-up. The mean follow-up was around 1.2 years. We are having the follow-up data of 2 to 2.5 years as of now. And last we have done 1 stunting 3 months ago. That is the latest one. And there was significant reduction in RVOT gradient from the mean 22 post-stenting to the pre-stenting mean of 77. There were no stunt fractures or any other complications we are seeing during the follow-ups. 1 patient had the increased gradient for which we have done balloon dilatation. During balloon dilatation, we had a complication of stent fracture, so we restented again for the patient. 1 patient in our group underwent already percutaneous pulmonary valve implantation with the Merrill valve 23 mm. We are having the 1 year follow-up data showing good results, which functional class reduced from 3 to 2, and others were on periodical follow-ups. Here we conclude the stenting is a feasible and safe for the post-op RVOT anomalies, high radial strength for RVOT obstruction, and low radial strength for no RVOTs. Pre-stenting, the RVOT can be done safely for the patients without RVOT also. This is a prospective, we are planning to have a large prospective studies further, and we already got ethics approval, and we are publishing the interim results at present, and we will publish the further results in the future 1 to 2 years down the lane. So this we hereby propose to have the elective RVOT stuntings in the cases of huge RVOT dilatation to prevent the RVOT further dilatation, fixed RVOT diameter. Thank you. Yes,
How
sir.
you predict it will going to develop the PR? It's not all will develop the PR. You do stenting now.
Yes, yes.
Your aim is to do the percutaneous wall in the future.
Yes, yes, sir.
But suppose if there is no significant PR, only stenosis, how you can predict in the future if there will be PR?
Most of the
Then
case,
suppose you are putting the stent, you are putting across the wall volume.
yes, sir.
Then you are producing, suppose with only stenosis, no PR, you are putting the stent, you are producing the PR, that means eventually you have to do the work. But if only stenosis is there, how you can predict there is going to be pulmonary regurgitation?
Basically, we involved these patients who had significant RVOD obstruction. So who had a severe stenosis for more than 50 to 80, that's what the study is about. So if they have a significant PR and we can see this RVOT is dilating like 12 to 40 mm in the matter of 3 to 4 years, then we know that this RVOT is going to be huge when they come to 15 years of age. We're not talking about the patients who are going to have mild to moderate stenosis by having mild PR, who's going to have not going to necessarily need a pulmonary implantation. We're looking at the patients where the severe PR and we're expecting an RVOT dilatation, and then the patients who have got significant RVOT obstruction, where the RV pressure is more than 2/3 systemic, that we should intervene these children either surgically or by putting a stent in. So in that case, we go for a stent, but with the view of putting up a valve in future.
But so one more thing, the RVOT aneurysm mostly, without only presence, it's not only because of the PR, it may be because of the patch also. It may be because of the, whatever the RVOT patch they are putting is the aneurysm. So even after repairing also, even after doing that also, that will still get progression of the RVOT aneurysm.
Yeah, definitely. That's the reason we think that, if you could stent them earlier, that stent can't grow with the RVOT aneurysm. It's just going to hold aneurysm with some endothelialization. That's a proposal study for future. We haven't done it. I mean, only one patient where there's no gradient, we put a stent, and what we do is we put a balloon across and distend the RVOT and look at the maximum distension, and we go 2 mm more than that. And what we propose, since there's not much of compressing force, you can use stent without much radial force. The idea is the stent embeds with this RVOT, endothelializes, and doesn't allow it to grow, and that's what we propose.
Yeah, what we are trying to see is that the width of the RVT is arrested at the width of the stent.
Yes.
Yes.
After the endothelialization.
Yes.
That produces RVT. In that
Yes.
case, can I just ask what is the length of the stent which you have used? How much of the RVT you have protected?
The length what we look at is basically about 3 or 4 millimeters below the narrowest point. So we position the stent center actually, basically from about what the stents we use makes 30 to 35 mm stents. We don't use larger length stents. So it acts as a landing zone there, and so it doesn't grow with the stent.
Okay. So I think your study is in the mid segment now.
Yes,
You are for
mid-segment.
long-term study, but I
Yes.
think that next time you have to see whether the main pulmonary artery segment and the branch pulmonary arteries, they also tend to dilate or not, because you have protected part of the RVOT.
Yes.
And one of the smallest babies were about 2 years, I think.
2 years, yes.
What stent did you put in that
We
case?
put a CP stent there.
CP stent there. Okay. So but given the diameter of the stent, in future, if the pulmonary valve replacement is required, then you have to put a larger diameter by cracking that one. That's what the idea
Yes.
is.
So CP stents can go up to what we put is 24 to 26 millimeters.
Okay.
So that the child who had balloon dilatation again because he developed stenosis on follow-up. So we did the balloon dilatation. There's a mild fracture. We put one more CP stent on it, and he's under follow-up. The RV dilatation is not significant. We are just waiting for pulmonary implantation.
I think the hypothesis that this is going to help is a very good one, and you need to do a longer term study on this one.
Thank
Well
you.
done.
Thank you, sir.
So one more thing, sir. Sir, any patient are having distal stenosis, because that will also affect your future, the
No,
plan
we-
for that actually, RPA, LPA stenosis.
In our group, we have not seen any distal stenosis.
Okay. Thank you, sir.
Quickly complete the session. Next case presentations will be from Dr. Vishal Kale, transcatheter treatment of superior vena cava aneurysm in a patient post-Glenn shunt.
Good morning, everyone. I'm Dr. Vishal from Wadia Hospital, and I'm here to present our experience with diagnosis and treatment of a rare complication following Glenn. So, brief history: our patient is now 2 years old. He was diagnosed as DORV, TGA, VSD, PS during neonatal assessment. As a child, was asymptomatic. He was discharged and was on regular follow-up. He underwent surgery, BDGS with MPA banding at 12 months age. He had a post-uneventful stay and was discharged on 7th post-op day. For the first follow-up after 1 month, he was asymptomatic, growing well, was saturating around 80%, and 2D echo showed unobstructed Glenn shunt with an MPA band gradient of 86 with an antigrade MPA flows. On 3rd month follow-up, the child was clinically stable, but there was mild facial puffiness. Saturation was still around 80%. 2D echo showed a functioning Glenn shunt with an aneurysmally dilated RSVC, which was measuring around 31 millimeter. And the antigrade flow, jet of MPA flow was seen entering the RSVC. So, to confirm the anatomy, it was planned to do a CT angiogram, CT pulmonary angiogram. So, it confirmed the diagnosis like SVC and internal jugular vein were aneurysmally dilated. SVC was measuring around 31 millimeter and IJV was measuring 11 millimeter with a patent Glenn shunt. There was no thrombosis or obstruction in Glenn shunt. So, we reviewed the literature, and it is a very rare condition to see SVC aneurysm following Glenn. We could find 2 case reports. This was one case which had SVC aneurysm 14 years after Glenn, and this was the second case. So, like in our case, there was no obstruction to the Glenn shunt, but as there is risk of thrombosis, embolism, venous obstruction, rupture, decision for intervention was taken, and as the aneurysm was suspected due to the jet of antigrade flow from MPA, due to a malposition PA band, transcatheter device occlusion of the MPA antigrade flow was planned. So like we took the patient to cath lab, like Glenn angiogram confirmed the aneurysmally dilated SVC, which was measuring around 32 millimeter, which was similar to the CT finding. So we did a RV right ventricular angiogram, which showed the MPA band was slightly malpositioned, but was and there was an antigrade flow into the Glenn, which was measuring SVC, which was measuring around 2.5 millimeters. So the termo wire was crossed through the MPA, through RV, RA, and into the IVC. The crossing was a bit difficult, but it was done, and the wire was parked in the IVC. So over the wire, we exchanged the wire for a stiffer wire, and a top sheet was crossed across the MPA, and it was decided to close the occlusion using a Amplazer 6x4 occluder device. So it was advanced through the sheath, and the aortic disc was released. And after the disc was released, the entire assembly was pulled back. Once the position of aortic disc was confirmed, slowly the remaining portion of the device was deployed. After deployment, angiogram was done to see if the position was stable, like to see for any shunts, residual shunts. So once the position was confirmed and there was no residual flow, it was decided to release the device. The post-release, the device remained stable. So the post-procedure, the Glenn pressures reduced from 11 to 8 millimeters. Child underwent the procedure without any post-cath complications and was discharged on post-cath day 2. On follow-up, like 1 month follow-up, the child is stable, still maintaining saturation around 80. 2D echo showed the MPA device is in position. The Glenn is functioning, and SVC size had reduced to 18 millimeter in 1 month. On 3 month follow-up, the child was still stable with saturations around 80. 2D echo showed the SVC size has further decreased to 13 millimeters. So we did a CT to confirm the echo findings. And the first one is the pre-procedure CT scan, and the second one is the post-procedure CT scan. The pre-procedure, the size was 31 millimeter. It has reduced to 13 millimeters. So so SVC aneurysms in Glenn is not well described. There are few case reports, so there were no specific guidelines. They have proposed that it can be due to deficiency in the longitudinal muscle layer of adventia. That's the two case reports that have described those things. But we thought it was due to antegrade jet from MPA in our case. These aneurysms are known to develop thrombosis, pulmonary embolisms, and or venous obstructions, and are risk of rupture. So in view of risk of sudden increase in size and thrombus formation, occlusion, generally surgical is recommended even in asymptomatic cases. But in our case highlights that importance of detailed evaluation for an antegrade MPA flow as a cause of aneurysm. Transcatheter intervention is a feasible treatment option, and optimal outcome depends on appropriate case selection, operator expertise. Thank you.
Saturation was maintained.
Yes, sir. It was at the risk of thrombosis.
Because
so we
sometimes
decided
it will be like a functional obstruction also. We saw some cases where it's a jet is going, so the gland flow also integrate flow will be get affected.
Yes.
So it's a nice idea sometimes even they develop the chylothorax, persistent pleural effusion when the integrate flow, when the gland flow is getting affected by the integrate MPA flow.
There are reports of antegrade flow causing SVC syndrome. So like it was similar to that, but there was no obstruction, and so we thought to intervene before the like if there is any thrombus or any obstruction. And as the size was continuously increasing, so it was planned to intervene.
Here, I mean, you have guessed that the SVC dilatation was due to the antegrade flow through the pulmonary band into like the jet was impinging on the SVC wall. Sometimes, even if do not have the forward flow, if there is a flow obstruction to any part of the gland or the branch pulmonary arteries, then also there might be some aneurysmal dilatation of the SVC. But in your case, I think there was no obstruction to the whole circuit in any way.
And repeated echoes didn't show any gradient or obstruction, and CT scan was done pre-procedure, so it
Yeah.
didn't show any obstruction.
Either in the forward flow through the gland, that is through the SVC into the branch pulmonary arteries, or into the whole total branch pulmonary artery system, you didn't find any obstruction. So in this case, you assume that the jet was hitting directly, like something like a Quanda effect, which is happening actually on the wall. Nice case.
Thank you, chairpersons. We will complete the session on free papers presentation. We are already running late by 10 minutes. We'll quickly go on to the next session. That is the plenary sessions. That will be to chair these sessions. I invite Dr. Snehal Kulkarni Madam, President PCSI 2019, and Dr. Rajesh Sharma sir. So please occupy the dais, sir. Dr. Shaunak Shah is there in the audience, and Dr. M. Jayaranganathan sir. Please occupy the dais, please.
Good morning, ladies and gentlemen. The next session is a debate, and the topic is consumables should be reused to limit cost of therapy. This is actually a very relevant topic to us today, and we are very interested in listening to both sides of this motion. The speakers in support of the motion Dr. Ashutosh Singh and Dr. Neeraj Agarwal. Dr. Ashutosh Singh happens not to be here, so Dr. Neeraj Agarwal is going to substitute for him, so he is going to take up the entire space. So both of them had 5 minutes each, so Dr. Neeraj Agarwal is going to take 10 minutes in support of the motion, and then we will have the speakers against the motion, which is Dr. Raja Joshi and Dr. Edwin Francis. So like in the debate yesterday, we are going to have 5 minutes per speaker, and then we are going to have a rebuttal for that. Okay. Dr. Neeraj Agarwal.
Thank you, sir. And I will start with this presentation that consumables need to be reused irrespective of economical status. No country in the world is able to sustain the model where they are not reusing. So this is our surgeon, the rich surgeon, who's saying, I have a lot of money and I can spend anything whenever I come to the lab or to the OT. I want everything from the New York, like we all know about New York, and I don't want anything from the Oxford. The other one is the, our single-use cardiologist having a lot of environmental impact. So this has a lot of economical impact and environmental impact, irrespective of the country status. There are few known and proven facts. Single-use devices are expensive, there's no doubt about it. Most single devices can be reused. Economic benefits from the reuse are huge, documented by various studies, and they should be passed on to the patients. Why it was made, that single-use devices were made in the beginning, why they were made? To reduce the reprocessing cost of the multi-use products. But over the years, as the products developed, they became more and more expensive. And so to the point that reuse had to be started again by the sterilization techniques. So is it a market-driven force to use a single-use device? Because if I'm a manufacturer, I would say, use my product only once. Even if it's a forceps, if it's a steel forceps, I would say, no, don't reuse it, because it's my benefit. So it's basically on paper. Manufacturer has to decide whether it's a single-use device or a multi-use device. And the manufacturer doesn't have to prove that single-use device cannot be reused. They don't need to prove it. They need to prove that the product is multi-use. Then there are a lot of hassles for a manufacturer. But for a single-use device, there is no hassles. It's an easy job for a manufacturer. So there is no statutory requirement from the manufacturer to provide validation to label a single use. Tomorrow you can decide that I will use a forceps also as a single use. What is the reuse policy all over the world? Currently, how the world is doing it? So there are few countries, Germany, Canada, totally legalized, in-house and third-party processes are available. It's legalized. Australia is legalized. In parts of Europe, it's a off-label use. And Middle East, Asia, Africa, it's a universal use, we all know it, but unregulated, highly unregulated. So US FDA says that reprocessing is possible with third-party processors if the quality can be ensured. The FDA has given approval. It's a government accountability officer was appointed, and report was published in 2008. They say no additional health risks were found from reprocessed devices. Reprocessors were considered as a manufacturers. Legal marketing rights were given for the reprocessed devices. Reuse is seen in India. It's very common because of financial reasons. 1997 CSI statement says, before reuse, you can reuse, but it should be retested for functional and mechanical integrity. For sterilization, there should be strict protocol, and anything which has been re-sterilized should be used within 6 months or re-sterilized again. So you follow a strict protocol. Is there evidence base on reuse? Are there any studies? Yes. There is a paucity of data that says there is a harm with the reuse, but there are multiple data which says multiple data says that they are secure with the reprocessed cardiac catheters, pacemakers, ICDs, guide wires. There are a few trials I will show. This was a Burton trial conducted in 1925, published in Circulation. They say it's a prospective major random RCT, inclusive of 1,000 patients. Reuse protocol was ethylene oxide. There were no significant differences in the safety and efficacy between new and old products. Then there are multiple studies. In 1997, they say 100 patients, no increased rates of complications. In a Israel center, no increased rate of complications. This study was interesting that they say, it's an experimental study. They said if you use the blood in the catheter, cannot be cleaned, then ETO sterilization may not be effective. So they emphasize that careful and standardized cleaning before sterilization is important. Viral load, we are always worried about the viral picture. The patient is infected, you reuse the catheter, this may be dangerous. But none of the studies say that they are resistant to sterilization protocols if you do the cleaning, washing, and ETO. This will reduce the viral load and catheters become sterile. Now, what about mechanical damage? We all say that if I reuse a balloon, this may be prone to rupture. That is basically a limit. If you limit the reuse to 3 times in a balloon, it has been found to be safe. This study was interesting study they conducted to check the mechanical damage with reuse, maximal tensile load and elongation of catheter rupture, and neither measure was changed after reuse protocol with ETO. So it was found to be safe and good strength for 3 uses. Again, profile of inflated balloon by this study did not change the burst pressure. They checked the burst pressure and it was not found to be changed. And they say the force required to break a catheter always exceed the force usually exerted upon in the cath lab. So unless you put the pressure more, the balloon or catheter will not rupture. Of course, you have to check the mechanical integrity when you are handling the catheter. This was a test also burst testing. They did the burst testing of the balloon and no significant difference was found in the burst pressure between reused and new catheter. They say if the catheter is manufactured wrong, like this, then even a new product, if you don't know how to handle it, even a new product can break or rupture. It's not about reuse, it's about safe use, about the catheters. So, this is the Indian data which say the average number of balloons used in BPV, BAV or BMV is 2.3. So if you're charging the patient for every balloon, the cost will be prohibitive for a lot of patients. They will not be undergo, even a government setup will not be able to handle it. EP catheters have been found to be up to 5 times reusable without any damage to the function. This is a meta-analysis, again says safety profile. CDC says reprocessing doesn't pose a risk to the patients. So now the concern remaining is infection risk not found, mechanical integrity, if you check it, not found, clean immediately, the sterilization is complete. The only issue remains is ethical now. Ethical and legal, I am till now, because we don't have a policy in India, we are worried. Here, hospital has to take the full responsibility for the safety. Consent, regarding consent, there's an article in 2000 guidelines by the North American Society. No ethical reason why this issue must be added to the long list of risks known to be associated with the procedure. Ethics says the consent part has to be handled by the hospital and by the society of the country. JCI says consideration should be given to whether the patient has the right to know if the reprocessed device is being used. But there is no force to take the consent by the JCI 2017. This was an interesting study. They say when they ask the patients whether you like to have a reused product, they say 2/3 said agreed that we are okay with the reused product. But this is America, I think, and where the people have belief that on the system, on the doctors. In India, it may not be feasible. So it should not be reused if you can't clean, can't maintain the sterility, can't maintain the protocol. if there is a significant damage, visible damage on the cracking, corrosion, flattening or blunting of tube, don't reuse it. Why do you want to reuse a damaged product? Maintain a quality system and dispose and reuse responsibly. You know, you should reuse only those things and not this thing, which should not be reused. So, reuse responsibly and not everything. Thank you.
Yeah, thank you very much, Dr. Neeraj, and it's an interesting debate. And now let's see the other party, what they say. The cardiologists and surgeons, I think they want to survive and then keep the programs comfortable and competent in spite of not reusing. So let's listen from Dr. Edwin. Edwin is a cardiologist from Kerala and don't want to reuse. Yeah.
Good morning, everyone. I just came a bit late. Sorry for the buses were a bit slow. So I heard it partly, I couldn't hear it fully. But when I was listening to Neeraj, it's like probably like the law minister was telling yesterday, probably I was listening to the news that there is 120 crores being spent on one day on October 2nd. That means the economy is booming. That was probably yesterday's news. So that's what probably Neeraj was speaking. They're not showing the real story behind it. So the topic here is whether the consumables to be reused to limit the cost of therapy. What I would like to say is, consumables should never be reused at any cost. So before I go, they say one picture may speak 1,000 words, so I show a video which may speak 1,000,000 words. I have a disclaimer. All characters, events, and names shown in this movie are not fictitious. Any resemblance to any person living or dead or to any events past or present is not coincidental and is purely intentional. And no animals were harmed in making of this presentation, but many humans were killed and many were gravely injured. So you can have a first case here. Sorry, this is, Actually, this is a case done by someone, it is an LPS stent being attempted on a severe LPS stenosis, in which, can you click on that, please? Let it play on that, at least my first video, and keep playing on all 4 videos. I don't want to delay. The second one shows the stent while being just positioned at the move to get an optimal position, it gets displaced from the balloon, and then being tried from the left side to snare it, it gets stuck on the stent. Then again, another stent is used. You can click on the last one. The stent gets broken off. When you're trying to pull harder, the snare gets broken off and gets stuck again. So I'm stuck with a stent which is displaced, 2 snares, 1 snare stuck, 1 snare broken. Probably somebody was smart enough to pull it out from the upper side. So I'm not showing that. So I have a narrow escape here. Next one. Again, there's some problem with the animation here. This is a patient who had been trying for undergoing a peripheral angioplasty. Catheter tip, it is again not shown here. The catheter tip gets displaced into the cerebral vessel, and there's a final angiogram. You can see here, this was the area which was tried to remove the catheter tip. There's an intracranial bleed, dissection, and next one. The patient never makes it. It was probably not as lucky like the last time in which could have narrow escape. Again, the third victim. Again, there's some problem with that uploading here. This is probably a very simple case. Somebody thought could have come out of the cath lab in 5 minutes. A recoarctation, a balloon dilatation, and the balloon never gets deflated. It's a real problem. It's completely occluding the lower part of the body blood flow. It is moved here. You can see, when you play on the second slide, you can see if it is carefully, every trick on the upper sleeve is tried, but then the balloon doesn't deflate. It's all reused balloons, obviously. In India, everything is reused. They say everything is safe, according to Neeraj, the previous speaker. You can see somebody even trying to put a stiff end of a coronary wire hard enough. You can see if you clearly look at it, it actually goes outside the aorta. Even then, the balloon doesn't get deflated. And then finally, An idea comes, a smart fellow comes in, probably tries to do with a per abdominal direct punch of the balloon and deflates it and saves the day. It's also dangerous. Then victim 4, I've written as N4 because I don't know what the N stands for, how many times, 1,000, million, I don't know. There is any Tom, Dick, and Harry been to the cath lab for any day or 2 days, you've seen this. Last, can you play on it? This catheter tip being broken off. Then some smart fellows try to retrieve it, it's almost reached the, and then finally loses it again into 2-3 places and here. Here's one final victim shown. Here's an angioplasty done for a coronary stenosis. 3 weeks later, come with tamponade, fever, there's a pericardial effusion. There is, if you play it, you see an abscess here in the coronary stent. It takes 3 to 4 weeks of antibiotics, CABG, to save the patient and goes home after 3 months of ICU stay. So just a few slides. What is reuse? A repeated use of a product which is intended for single use. Use of devices, catheters beyond the expiry period, which is never gets mentioned in the literature outside India or this developing world. Who is really benefiting? Are the patients benefiting? Recently, there's a capping of the stent cost. Did any hospital or management reduce the cost of the total procedure of the stenting? I don't think so. So who is benefiting in the process? It is said that it is the patient. Patient never gets benefited. It's the hospital or the management or a few unscrupulous professionals. And who is losing? Finally, we are losing. A few unsuspecting patients, obviously, and then we doctors or the interventionalists who struggle in the cath lab, all the stress involved, radiation, and we and our families the losers. The cost advantage is the only thing, the argument they have, but I'll just show you one slide in which when I started my career, an ASD device was costing over a lakh, a PD device 50 to 60,000, a coronary stent 60,000 to 1.2 lakh, 1.5 lakhs. But now, 2 decades later, the cost is half or 1/3 of the primary cost we started off. While a petrol, which was costing 26 rupees in 2000, is now 76 or 80. A gold, which is 4,400, now costs 40,000, but nobody's complaining. Everybody's using it. There is no dearth for requirement for gold or petrol here. But when it comes to medical therapy, everybody is scared of, you want this, money is increased, costs have gone up. When there is human lives, there is no value in India. At this time, I'll just go to a few more slides. There's a cost efficacy modeling. They say, the study, when you have even a modest increase in complications, or if there's a need for a urgent revascularization, it may offset all the benefit which you have done. Can you make it full screen? It offsets whatever benefit which has happened. So our modeling was instinctive that if the catheter is reused associated with an even modest increase in clinical complications, any potential saving is lost. So I would love to reuse a device if there's a decent national policy on reuse. Each hospital is adhered to these policies and there's some check on the procedures done, which never happens here. This is another article in which I think the implementation of stricter regulatory environments will improve patient safety and monitoring of reuse practice, but not necessarily improve cost effectiveness. So the one and only argument doesn't hold true. And if you are doing it in a proper way, like the FDA approves, then the cost of a reused device is nearly 40 to 69% of the new device. That's an FDA study. So in India and Brazil, where the prevalent is completely unregulated manner, aimed at purely reducing the cost, it almost always there's a compromise of safety. Then one more argument, I think they didn't say that there's waste reduction. That's the only other argument other than cost. The last slide probably. So it depends on the level and type of control needed, they say. So you have class 1, class 2, and class 3 devices by the FDA, of which the class 3, which requires the most stringent requirements, comes only at 10%. So there is no question of waste reduction also here. It's only a small percentage. And my final slide here, I just want a question of you, to Neeraj or one of the friends who want to reuse. If one of your loved ones comes, I'll obviously use only new ones. Thank you.
Thank you, Dr. Edwin. I would now like to have invite Dr. Neeraj Agarwal on the. Yeah, no, we want to throw the debate to the floor. He speaks later. So, can we have Dr. Neeraj Agarwal back on the stage? You can just have a chair here, and Dr. Edwin, you too. I'd like to throw the debate open to the floor. Yeah, Dr. Jagannath. Can we have the mic to Dr. Jagannath, please? Mic.
I have a question for you, Neeraj. You said that single-use plastics, I agree that single-use plastics in India is banned. Many states have ratified it. But single-use itself, when it is branded, becomes multiple use in India. And multiple use, if it is permitted, how many uses are actually being practiced? Are there any guidelines which say that it should go back to the manufacturer for practice? I mean, for re-sterilization? What is the shelf life of that particular re-sterilized thing? And what are the mechanisms which are prescribed? Are they being followed?
So that's what we are saying. The system in India is unregulated. Otherwise, there are fixed guidelines. For each catheter, they say they can be, the manufacturer doesn't say that it can be reused. But the studies say lot of hard catheters can be reused for 3 times, and the balloons can also be used for 3 times. EP catheters can be reused for 5 times, but quality check has to be maintained. So you can't say that I will use it for 10 times, 50, till it ruptures. All these cases which he has shown is all those cases which are being used for 10 times. There's no limit. They're not labeling them that it should be labeled once used, twice used, 3 used, and then throw it. They are being used without any counting. So this is one thing. Yeah, so guidelines from the US FDA, if you find out, FDA US approval, there are guidelines. They say that these catheters can be reused for so many times, and these balloons can be reused for so many times. But again, one more thing is manufacturers. Like, manufacturers are not entitled. Now, this is the third-party processors. In India, we don't have, but in Western world, in US and in Australia, we have government-approved third-party processors, which are entitled to, they are like manufacturers. They are called legal manufacturers, legal reprocessors or legal manufacturers. They are allowed to work and reuse the products. So I think if we can, they can do it, we can also do it. But they say we need to reuse it. We cannot afford this system of not reusing it. You can't avoid it.
Thank you. Anybody else?
One issue which has not been addressed by both the speakers is it is all right if you put this issue of consent to parents or the patients who pay for themselves, either for the procedure or the hardware. Suppose if a hospital does all the procedures under charity or by public fund, where do we draw the line? Where do we put the issue of consent to the parents? Suppose the parent says, I'm getting it free, but I want everything new. Where do you put this issue? It's an ethical issue.
Yeah.
And another thing I think which comes from the corporate hospitals, if you reuse the balloon or any kind of a hardware and you charge it, I think that was the government's argument against that, against this many corporate hospitals. And I don't think our patients understand this difference between a reuse and a non-reuse. And especially, as you said rightly, in a public hospitals or a free models, do they? Hello?
Argument is that the quality is as good as the first use. Then you
How,
don't need
that's the whole thing. I mean, how you decide whether it is how to assess the quality of that product. And we know that it cannot be the same as a new product. That everybody you visit, always we will like to have a new balloon or a new stent or everything new rather than a reused one. Yes.
So I just want to know, like these patients with an RHD mitral stenosis from this August audience, how many times does a government or a private hospital reuse a PTMC balloon? Like, I mean, are there anything or...
Do you have an answer because you may be doing more?
PTMC balloon. The cost of the balloon and practical and like...
Can be used.
And do you find some trouble, sir? Do you find some trouble?
Rather, your experience?
Sir.
Reusing the Innova balloon for mitral balloon volume? Yes.
Yes, we do reuse it. I know hospital like GB Pant would claim that we use it for 6 times, but I think we reuse it only once, and after that we don't reuse it.
I know that I have written one paper some 20 years back.
Well, and SIM, both we reuse it once, but after that we don't reuse it. But I know hospitals like GB Pant who would use it 6 times. When I was in Sanjay Gandhi, they would sterilize it and use it.
Without any evidence of additional complications,
Yeah, there is itself a contradiction here. There's one person uses for once, like and done 6 or 7 times, some maybe 10 times. And who is checking on this? That's a concern here. And in a balloon, how is quite difficult to clean it. It all depends on the technician or a proper guy who's how
It's very
meticulously cleans
difficult
it.
to clean a balloon.
It's not an easy task.
Now, in fact, I remember when we were a fellow, we have written a paper of increased risk of infective endocarditis following reuse of balloons for metal stenosis.
Actually, I don't place institute. There have been an institute in which there was an epidemic of infective endocarditis after using a PTM.
I'm also aware that about a decade ago from Hyderabad, from Care Hospital, there was a series of patients who had endocarditis. And they were all Pseudomonas endocarditis, which was actually reported by Professor Somaraju.
This hardly gets reported, actually, these things.
Okay, thank you. Now, the last one we'll listen from Dr. Raja Joshi, a surgeon's perspective about how he can survive without reusing.
Good morning to all of you. Thank you, jurors. My job is to lay a strong house over the strong foundation that Edwin has already laid. And I'm against the motion to reuse consumables. And hearing what Neeraj said, Oxford, the first time I heard Oxford, something like this came to my mind, or maybe something like this, or maybe something like that. But there's new definition that I've got for you. I think it refers to a single-use device being readied for use again on somebody. So we've heard the sides where we've heard what the hospital thinks, what the finance thinks. This is a very interesting study published from China quite recently, and it is talking about responders of people who have received these devices or are planned to be received on. They want just two things. Significant number of responders want safety, and they want the prices or the advantage of the price to be carried on to the person on which this device has been used. And primary goal of any procedure in the surgery or the cath lab is hygiene. Disinfection and sterilization are essential for ensuring medical and surgical instruments to be safe for use, not to transmit infectious diseases. We have, strangely enough, Neeraj and our papers have the same JCI guidelines. I'm picking out different paragraphs from the same guidelines. So I think even JCI white paper has dichotomy, does not tell you clearly whether you should or not. But they're giving you guidelines, at least we are talking about it. That's the healthy part. There's a picture in the same guidelines that how we found that this particular catheter that we thought was clean for reuse, and mind you, this is not a plastic, this is metal. They cut it across and they found it's impossible to clean it. And it says there's doubt and proof of the doubt. So I think this picture is a million words there. So what is the problem? Neeraj quoted that Germany has a very high incidence of reuse. The study out there, this is in 2002, 11% of the things that were presented for reuse in a sterile package, not just the sterility part, it's how you package it. 11% of the sterile packs were damaged. Who's going to ensure that? 33% of the devices were incomplete. Say, for example, some systems reuse HFO circuits. HFO circuits have got so many small little parts. It is costly, I understand, 35,000 rupees for the circuit to get opened. But it's got such small, intricate parts. One small part not being available, you're going to use something substandard to plug a hole inside the circuit. So 33% of the devices were incomplete or the parts were missing. 54% did not meet the criteria for functionality. This is coming from Germany. I presume the quality is going to be good. So they concluded that however best you do it, the inadequacy of reprocessed SUDs is increasing the risk of the patient. So that is the bottom line. So there are systems in place. I agree with Neeraj that there are countries where they have started talking about it, gone on to FDA approval kind of stuff, but all of them are ultimately questioning the functionality. Sterility, okay, we can maintain. Functionality is another problem that we face. And in India, there's no third party, so these are the guidelines that they want us to answer as questions. Who has authorized us to do that? Who is going to limit the number of uses, the argument that was just presented here? How many times are you going to reuse it? Who is determining that fact? In India, nothing gets thrown away. Even the toothbrush is, till the end, it's going to be used for many, many different indications. So we don't have those guidelines in place. So in a country where we are talking about reuse, we have to be very judicious. We have, despite a good attempt at cleaning and reusing, there is a significant risk to the patient. The devices and supplies are often complex in design, and the cleaning efforts, either by hospitals or third-party processors, may still remain inadequate. Reprocessing and reuse may compromise the product's performance, and the manufacturer is not liable to it, because he has said it's a single-use product. So, even when since 1970s, this process of reusing has been happening all across the world. But the line there in the red, they don't meet the same criteria for. They should meet the same criteria for reprocessing by the original equipment if we are using a third party. Now in India, there is no third party who will guarantee you that. So the liability again comes back onto you. There are major concerns raised by the WHO itself. They said the design may not be such for decontamination. They may alter the device characteristics, do not undergo extensive testing before they are reused. The cross-infection rates are definitely there. Can absorb chemicals during the process of reabsorption, changing the material strength, material quality. So again, the concerns are emphasized here. Reprocessing changes the design. I'll just show some examples here. This can't be an acceptable standard for protocol to sterilize anything. I mean, you dip it for 5 minutes and took it out like that with the Chittle's forceps. It can't be. Can't be. And this is just an example from a surgical field. You see, you can easily make out the new cannulas and the old cannulas. And many of the surgical friends of ours will probably agree with me. The aortic cannula is tied practically at the same point all the time to secure it's not moving in and out. And it definitely starts weakening. The wire reinforcement starts weakening. And there will be an accident waiting for you one fine day. And I don't know what number of time the cannula has been come back. I've never gone to check how many times this cannula has been reused again. So technical issues, the ones that I just mentioned, ECMO cannulas being reused, and a vessel that you are going to use for access in a sick child getting traumatized because of bad, reused, kinked ECMO cannula. I think these are and it's a sick child. So accidents are just around the corner if you're going to continue using this, and surgical costs and repercussions are beyond control of cost then. Who takes the legal blame? Are we consenting for the reuse? As Dr. Snehal pointed out, is our society ready to understand the legality issue related to the reuse? Risk versus benefit. Government policy in India is to be against it. They're very clear about it. Most hospitals also will not stand by you when you're fighting your legal battle in the courts. So the person who will be at the end of the rope is the person who has used it. So this study in 1996 from Australia, I mean, they've said that the big hospitals, a large number of hospitals are in the process of reusing. Larger bedded hospitals are more likely to be reusing it. Cleaning and sterilization was satisfactory in only 59% of patients, situations. And the main reason given from each of these collected data hospitals was they were wanting to cut cost. My take on the cost issue, projected and actual is very different. You keep saying that it's high. I disagree. You know, which organization has ever cut down the cost of any procedure because of reuse? So I think it's an oxymoron. Reusing something which was meant for single use is as best as I can quote it. It's an oxymoron. In a country, I mean, I was attending the intensive care section yesterday. There was a big argument about, we see very early infections, we see very early gram-negative sepsis, our Pseudomonas rates are this, our E. coli rates are this. We keep blaming our hygiene, we keep blaming our sterility techniques on the hand washing stuff. Yes, agreed. I don't say that we shouldn't be talking about that. But a little bit of attention onto how many times have we reused stuff and we haven't even looked there. So I think infection rates are definitely high because our reuse rates are extremely high. And it's not just the infection. I think there is endotoxin still there. You can't wash it off completely. Endotoxemia, the low cardiac output. When we go abroad for fellowships, we see that the patient coming off from the theater is dry. And out here, we are struggling with getting free water out of the patient, low cardiac output. And as I just told you, everyone has to draw a line. Yesterday we heard Dr. KK that everyone should draw a line somewhere, and we have to decide where to put the line. But who draws it? How many times do we use it? And what do we consider important enough to reuse? I have seen people reusing Ioban. How does that save cost? Ioban, even when you sterilize it again, I think it's lost the iodine reaction property. So I think that's just an eyewash. Device failure and functional integrity we've talked about. Primary motive of a financial benefit, I really think it's not true. I mean, I still am not coming to terms with the fact that we are doing funded patients and we are doing paid patients. The life still remains as precious. And I've already highlighted on the legal and ethical issues. So I rest my case, my lord. Thank you.
We now have a rebuttal.
Cath lab items, but is there in guidelines how many times we will use the catheter? Because with the passage of time, every item has got a wear and tear, and gradually it loses functional integrity, so it may fracture or tear inside the body. How many times you will use and use? Is there in guideline? Suppose in the cath lab, once upon a time, I used Embart catheter. Our neurology department uses our cath lab. So that tip of the catheter fracture inside the body. Then I asked our cath lab nurses when this catheter was purchased, what was the expiry time? Because then I learned that it was purchased 5 or 6 years back. And it was thrown inside the body.
Excuse
so
me,
is
sir.
there
Can
any
you
guideline
shorten your
regarding?
question? Can you shorten your question in the interest of time?
I want to know that we listen the use and uses, but what I asked that is there a guideline? Suppose there is a question about Inui balloon. Suppose I use it once or twice, or I did not use it at all. But for how many years I'll wait?
Dr. Neeraj, the question is how many times can you
That's the
reuse?
question. See,
Yeah.
at least you check the device before using functionally. Even you wear a shirt, what do? You check it, that it's not torn from anywhere. So at least see the tip of the catheter, see the breakage points before using it, flush it, see the fluid is going through the catheter. These things, at least in any reuse, this has to be seen. Even in a new catheter, you can have a breakage. So
Madam,
that's what I'm saying.
Yeah.
I'm coming to the
So,
Madam,
if I can intervene in
sir,
that.
Sir, 1 second. Suppose in case of Inui balloon, there has been question how many times I will use it. I have the Inui balloon, which I purchased 10 years back, because we don't now have the rheumatic mitral stenosis patient. I cannot use this. So, after how many years I should use it? Even I did not use it for a single time.
So
But there is balloon in my cath lab. Okay.
these points will come out in the rebuttal. So let's have Dr. Neeraj give the rebuttal, and then one of you can decide, one of you, since there's only Neeraj on the other side, who has to rebut.
Yeah. So, see, I would have this slide only. So this is going to stay because of main reason that lot of patients, see, what Dr. Edwin says, the economic benefits have to be passed to the patient. See, I have a patient of severe coarctation, I saw 2 days before. He doesn't have money, he needs emergency ballooning. Tell me a system where a patient can get an urgent balloon dilatation of a newborn coarct in less than 20,000 rupees. Tell me. If you use all the consumables which are balloon new, and the patient going to die. I know this, patient going to die. Tomorrow patient going to die. This patient is not uncommon in India. I have seen it. If I'm using the balloon, I did this balloon 2 days before. I used 3 balloons in that patient, and I did charge on less than 20,000 rupees. Yeah. This, I'm not trying to be Robin Hood. You can't be a Robin Hood here. But you have to think judiciously. You have to see your house. What is your house? How much you should eat, and how much you can give it to outside.
Your 2 minutes are up. Yeah. Dr. Edwin or Dr. Raja, you want to rebut?
I can't rebut too much because he's my cardiologist, so I have to listen to him. So the thing is, my humble submission is that costs are something that we should develop a system to work around. There's no cost to the price of life that we are seeing. We can't cut short on things which take care of quality. I was talking to somebody the other day. I think in India, whenever you talk about a cheap car, what do you think gets struck off their list first? I think it's a safety feature of the car. The airbags, they go. So this is what is happening here. We are compromising on the safety of the child just to justify, somebody's greed need to get fulfilled. I don't know, it's not the greed of the doctor for sure. I'm quite sure about that. But there's enough for everybody's need, not for everybody's greed. So
Thank you, Dr. Raja Joshi. Thank you. That was a very interesting and enlivened debate. My own take on this after listening to all this is, and with my experiences, that whenever you reuse and you have fever post-operatively or inflammatory response, then you don't know what the hell is hitting you. Either it's the reused catheter or is it anything else? And the cost of meropenem and colistin and whatever else that goes into the patient is far outweighs the cost of the initial new catheter. That much I know. And a new addition, what Dr. Raja Joshi said, is the suction tips that we use in the operating room, which are metal. But their lumen is so small, so they also, they are not safe to be reused, and we are reusing them all the time. So there are many questions in our minds when you land up in a situation like this. And I don't know whether it's, it's always safer, I suppose, not to reuse, but is it practical? Probably not.
As you rightly said, the government has made a rule for not reusing, and we can't legally reuse it. But on the other hand, a procedure like balloon mitral valvotomy, the government gives a reimbursement of 30,000 rupees when the Innova balloon costs 1,10,000 rupees. So we are in between the government policies, and I think as clinicians, we have to find an effective way and have our own ways of sterilization and strict guidelines, and that's how I think we need to work. Otherwise, we have to send some part of patients back. That's my...
The healthy indication is that we are talking about this in this forum. I think this is the first step.
So we put the motion to the House. How many people are for reusing? And somebody has to count. I think this will be like 50-50 is going to come. Can somebody just count hands? This is for reusing? Okay. Against reusing? I think for reusing were more. 60-40. Closing remarks. Take a mic. These are closing remarks on this session.
It's not that the government says don't reuse, because this is a mistake which many people think, because we also went through this. What we have to do is formulate a policy on reuse. And once we formulate saying that I will reuse it this X number of times, it should, and how are we going to count that it is going to be this thing, and the sterilization protocol. Another thing which many people are talking is about the cleaning. One of the things that you can do is now there are biofilm digesters available, and if they are used, this will remove the lipoprotein and other chemicals which are there, and it can be reused.
Thank you, Dr. Prasanna. And with this, we close the debate. Thank you very much for everybody for your participation.
So it was a lively debate to begin the day. I thank all the chairpersons and the speakers who have contributed to this debate. So we are already running 15 minutes scheduled behind. So let us begin the next session. The next session will be on research and innovation. I call upon the following persons to chair the session, please. Dr. Smriti Ranjan Mohanty. Dr. Smriti Ranjan Mohanty. Dr. Amitabha Chattopadhyaya, please make into the dais. Sir is coming, Dr. Amitabha Chattopadhyaya. So following this session, we have a fetal rhythm workshop going on. So I would like to request the persons who are interested in taking part in the workshop to occupy the middle of the audience hall, please. So that the workshop is moderated by Dr. Sejal Shah Madam, and that workshop contains a pre-module quiz followed by a workbook exercise which will contain all the exercises that will be explained by Madam as the course goes on, and there will be a post-module quiz in that session. So whoever wins in the post-module quiz will be appropriately rewarded with gifts. So there are 2 prizes for that, first place and second place. So I would like to inform with this opportunity that whoever is really interested in taking part in the fetal workshop rhythm has to occupy the middle of the rows, so that it will be very easy for the moderator to conduct the workshop. And I would request even to keep the first row empty, please, because the speakers who are involved in the workshop will be occupying the first row. Thank you. Dr. Amitabh Chattopadhyaya, please. Dr. Smriti Ranjan Mohanty. So I would like to request Dr. Amitabh Chattopadhyaya to please conduct the session.
Good morning. I'd like to invite Dr. Graham Stewart, who is a consultant cardiologist, good specialist, electrophysiologist and intervention cardiologist at the University Hospitals Bristol NHS Foundation Trust. Welcome, Dr. Stewart.
Right, ladies and gentlemen, I'd like to thank the organisers for inviting me to talk on what is a very exciting and rapidly changing aspect of cardiology, that is the development of leadless pacemakers. So what I want to do is talk a little bit about the history of pacemakers, which is a very exciting and interesting area. I want to look at why we need new technologies. I want to look at what leadless options are currently available, and perhaps think a little bit about future options that might be available or just around the corner. So the very first pacemaker came about at the same time as the very first cardiac operation in the mid-1950s. Here we have, this is the pacemaker. It was an external pacemaker. And you can see it was attached to the mains electricity by a cord, so it was obviously very limited. The next stage was a battery-powered pacemaker. This is Walt Lillehay. And this worked reasonably well, but again, it was external. And it was in the 1960s that we developed the first pacemakers that could go under the skin. Again, they were initially epicardial, but throughout the mid-60s, we developed transvenous leads. And there were huge advances in pacemaker technology after that. In the 1970s, we developed leads with both tines and with active fixation screws. And that led to the ability for us to put in endocardial pacemakers with leads going down through the vascular space into the heart. Sorry, this seems to be... Oh, that's it. Bear with me a second, I'm afraid. Can we move the laptop out here? Pointing towards you. Right. So by the 1980s, we had steroid-eluting leads. We learned that if you put 1 milligram of dexamethasone behind the tip, then that improved the features of the leads. 1990s, we got more programmability. We got smaller pacemakers. And by the 2000s, all these different innovations and advances. And this led to the first subspecialization amongst cardiologists in pacemakers and electrophysiology, and that was also with pediatric cardiologists. So why then do we need new technologies? Well, because the Achilles heel of the pacemaker, the area that's the most vulnerable is that of the pacemaker leads. And that's especially true in children. So what I'd like to do is look at some of the reasons why this is true in children. The first issue is, of course, growth. Do you want to do my hand? If I just say next slide, please. Next slide, please. And next slide, please. So this is a single child, and here we've put a loop into the right atrium, a pretty standard approach. And this is the child aged 16 months, and this is the child aged 3 years. Next slide, please. But the problem is that loops don't always unfold with growth. And this is a pathological specimen showing the many different fibrous adhesions that can go to the wall of the heart and indeed to the tricuspid valve. Next slide, please. And that can lead to valve damage. It can also lead to the pacemaker lead adhering to the walls, which can result in perforation if you have to remove the lead. Next slide, please. Could you click on the video, please? Or just move past the video. In addition to growth, there's also a problem here that you may just about spot, and that's here. Next slide, please. Next slide, please. And that is fracture. And here you can see a pretty classic fracture where the lead has been caught between the first rib and the clavicle, and there's a breach in the insulation of the lead. Next slide, please. So why is it that fractures are much more common in children and young people? And there's approximately a 30% risk of a lead-related problem within 3 years after implanting an endocardial pacemaker defibrillator in a child. Next slide, please. And the answer to that is arm movement during exercise. Next slide, please. And again. So this is an example of what happens. So this is the Cardiff half marathon from a couple of years ago. And this is what happens when you wear one of these watches that tells you your cadence. It tells you how often you're moving your legs. If you assume you move your arms in the same ratio as you move your legs. Next slide, please. Then, we can just leave it there. So then what happens is you're moving your arms about 20,000 times during that half marathon run. Next slide, please. This is, I don't know if you can click on that video. This is the way Medtronic test their leads. This is a rig which moves the lead up and down, up and down. I use a Medtronic Select Secure lead, which is a cable construction lead, which is still the toughest lead that is made. Next slide, please. It's ideally suited for children because it's small. Next slide, please. Next slide, please. But they only test it for about 2 million cycles, which is equivalent to 100 half marathons. Now that sounds a lot. If you're an endurance runner, it's not a lot. It's about 6 months worth of training. If you're a child, children probably move their arms about that number of times in a couple of years. So hence, it's not surprising that an active child were more likely to reach the lead. Next slide, please. And move on, please. Next slide. So the growth is the first issue. Next slide. The second issue is what happens when you put leads through small veins. Move the slides on, please. And that is venous occlusion. If you can click on the video. You can see here what's happened. So there's a lead going through here. There's a hand angiogram into the left arm vein, and there's complete occlusion in the innominate vein. And next slide, please. So that's why we need new technologies. Basically, there's growth issues, there's venous occlusion issues, and there's fractured leads issues, which are particularly bad in children in comparison to adults. Next slide, please. So what then are the leadless options that are open to us? Well, there's options that are already in existence. So the subcutaneous defibrillator is now readily available. And next slide, please. What this does is you've got, instead of putting anything inside the vascular space, you've got a device that goes under the arm, and this is all a subcutaneous lead. And the shock goes between the box under the arm and the lead, which is subcutaneously parasternally. Next slide. And this is what it looks like. It's a big, bulky device, so it's not ideal for small children, although we've put them down and put them into children as small as 20 or just under 20 kilograms. Next slide, please. So that's one way. It's very large, though. Next slide. It doesn't pace. So the question with this session was how do you put leadless pacemakers? This is not a pacemaker. Provides only post-shock pacing. There are other technologies you can use, for example, to minimize the endocardial leads. This is a small child with a defibrillator attached to an epicardial lead with a subcutaneous coil rather than putting the coil into the vascular space, and that can work very effectively. Next slide. Or one approach that we've been using, which was pioneered by Eric Rosenthal, was to use an abdominal defibrillator with a subcutaneous coil, and this is one of these very thin, select secure leads, which is endocardial. So there's still an endocardial aspect to it, but much less than otherwise. Next slide, please. So these are the three leadless options. These are the three leadless options which we have available to us now: the Medtronic Micra, the St. Jude NanoStim, and the YCRT system. Let's look at the Medtronic Micra. This is a video that basically just shows that what you do is you put a 27 French sheath, that's the size, 27 French, into the femoral vein, and through that you implant a pacemaker which is allowed to sit directly within the heart. For the sake of time, I'll move on from that. The device, in theory, can be removed, but in practice, in a child, you would never remove it because it's got legs that adhere into the myocardium, and I think there'd be a very high chance of causing cardiac damage. And it can occasionally embolize or perforate. Next slide, please. And this is just to show the one and only embolization we've had. This is down into the right pulmonary artery, and it was managed to be retrieved, but clearly that's a problem, a potential problem. The biggest problem, of course, in children is that it's a 27 French sheath. Next slide, please. And just move on, please. And next slide, please. Can it be used in congenital heart disease? Well, yes, it can. We published actually in the Indian Pacing Electrophysiology Journal a lady who had basically no venous access to the heart. She had a CP shunt, she had an IVC occlusion, and we put in a leadless Micra, and it worked extremely well. Next slide, please. She'd already failed an epicardial and a direct transaxial approach on 2 occasions, and it was not possible to have an epicardial leads inserted. Next slide, please. But the Medtronic Micra at present is only VVIR, so there's no dual chamber option for the Medtronic Micra. Can it be used in children? Well, it's been used in 2 case reports I'm aware of. The first was a 27-kilogram girl. They opted for the Micra, according to the paper, for long-term outcome reasons. I think that's extremely unwise, and there may be something that they didn't say in the case report. But basically, once that device is in, the only way to replace it is to put another device in, which, given that the device is the size of a small bullet, that's not a wise thing for a child. Next slide, please. Just a few weeks ago, there was this case. Next slide, please. Was a 19-kilogram pediatric patient, and this, I think, was a good indication. They put it in through a superior approach, and this particular child had a life-limiting illness. Her prognosis was less than 10 years, so the battery life would later last that time, and really had high risk of putting in an endocardial system, leaving a lead in for various other reasons. Next slide, please. And next slide, please. The St. Jude NanoStim was the other main competitor to the Micra. It came out around about the same time. It's slightly smaller. It has a screw that goes directly into the ventricle again. But it's currently off the market and has been since 2016 because they found that there were unpredictable battery issues. Next slide, please. It's a smaller device, but at the moment it's not available. But what they are doing is they're working on a dual chamber system which will communicate through an atrial sensor by Bluetooth. So that's a technology to watch for. Next slide, please. This is the third option. This is something that's not available at the moment, but will be shortly. So what you've got here is you've got a system whereby there's a sensor that communicates ultrasonically to a small thing about the size of a bead of rice that goes into the ventricle. And that causes biventricular pacing. The problem at the moment is that sensor needs to also be triggered by an existing endocardial pacemaker. So it's not available for unless you've got an existing endocardial pacemaker. Next slide, please. Just about finished. And next slide. So these are some of the leadless options. Next slide, please. What about the future? Next slide. Well, this is one technology people are looking at. This is a proposal for a pacemaker that goes directly inside the pericardial space. It's still at an experimental level. Next slide, please. And of course, the most exciting advances will be this, where you actually harvest the heart, the cardiac motion to power the pacing circuits, because most of the size of a pacemaker is in fact the battery. Next slide, please. So in conclusion, at present, only device available to us is the Micra, which is very large, 27 French sheath, not ideal for children. There are new devices around the corner. Next slide, please. Thank you.
Thank you, Dr. Stewart, for this enlightening talk. Yeah, we'd like to call upon Dr. Ralph Maska, Pediatric Cardiothoracic Surgeon from Langone Health, New York. Good morning and welcome.
Morning. Thanks for asking me once again to talk about a little bit different topic, a surgeon talking about imaging, but it has become very important for cardiac surgeons. So this morning I'll be talking about some applications of 3D modeling for complex congenital heart disease. So the truth is that most of what we do is we have perfectly adequate imaging with echo, CT, and MRI. In fact, we're spoiled because 30 or so years ago we had none of this. And so we've become quite a company, quite used to using this imaging, and in most cases, it's very good. Okay. All right, but there are some limitations when we start looking at more complex anatomy. 3D virtual modeling is synonymous with volume rendering, but it's different from segmented basic modeling. 3D printing allows us to print replicas of particular patients' hearts, which gives us a chance to hold it in our hands and actually look at the anatomy. And it's another step in the gateway to personalized medicine. So again, I'm not here to knock our current imaging. I think we have excellent imaging. The CTs and MRIs are now acquired in 3 dimensions. They're gated to the cardiac cycle, and we have excellent anatomy. Here's some examples. On the left is a CT image in the axial plane of a 2.5 kilogram baby with very complicated heart disease. And what we can see is, at least in this 2-dimensional rendering, the imaging is very good. And on the right is a volume rendered image of a patient, a different patient with a sinus venosus ASD and partial veins. And you can see that for the vascular anatomy, it's a beautiful picture, but it's hard for us to combine both in one. So I'm told that this is often my response when we do these imaging to very complex patients. They're beautiful images. It's hard to understand from those images, and sometimes we have to figure out in the operating room, even given all that technology. So what is the problem with traditional imaging? Well, it really boils down to one thing, and that is we're looking at a 3D image set in 2 dimensions. And if you sit there for a long time with a virtual image in the imaging room, you can get a pretty good idea of what's going on. But it's really less useful for the surgeons and interventional cardiologists than to have a model in your hands. So with advancements now in imaging acquisition, post-processing techniques, and printing technology, and slides, there we go, we're now able to use 3D printing. The first 3D printed object was actually an eyewash cup, and then it was used in the automobile industry, and then over the next 5 to 6 decades, it's really taken off in all industries. The first report in heart disease was in 2008. So what is 3D printing? Well, it's actually a process of additive manufacturing where you build a model by adding layer by layer by layer. There are many different technologies to use it. Fused deposition modeling is the cheapest. What they do is instead of using ink, they use thermoplastic material, which is put in a semi-solid state and then extruded in beads and layers. Again, it's cheap. It's easy to do, but it doesn't give us the definition that we need in congenital heart disease. The next one on, I think, was a laser sintered technology, which is mostly used to create images in metal, and it's used mostly for prosthetics and orthopedics. Yes. The next one is polyjet printing, which is the one that we use most often. And in polyjet printing, it works like an inkjet printer, but instead of using ink, it uses a photopolymer that when exposed to UV light solidifies, and we're able to get very thin layers and get nice images.
We'll wait for the images.
And the last technique, which I had some nice pictures of, is stereolithography. Here we go. So we went through laser sintering, went through the polyjet, which is this here, which doesn't look like it's going to work now, the movie, but in any event, we talked about that. The last one is stereolithography, where chemical monomers are cross-linked when they're exposed to light. And the nice thing about this one is it can give you a very transparent model that you can look through and can be useful, for, especially for the cath people, to see catheters through. So how's it actually done? Well, the first thing is to take the information we already have with computer-aided design modeling and to create this segmentation of the heart that you want to look at. Then we can create a 3D surface model and then print that model using one of the techniques I just showed you. So the question is, great, that's nice, but does it actually add value? Because it can be very expensive. So where it can be used is pre- and post-procedural planning, patient education, and also training of students. And I think all three are very important, but I'm just going to concentrate on a few examples of the pre-procedural planning. Okay, here we go. So these are some examples from some papers that we wrote recently. On the left-hand side is an anterior muscular VSD that you can see there's a tape through. And on our preoperative imaging, it was very difficult to understand why we couldn't clearly see the VSD. It appeared like there were two jets on some of the images and one on another. And you can see pretty clearly that there's a muscle bar that runs through it. And with that information, I was able to go to the OR and through the tricuspid valve very easily close it. But you could see how that inferior part of the defect might be easily missed if you didn't know this from the modeling. And on the right-hand side is another patient with an apical muscular VSD, which you can see there are multiple holes typically on the left. And on the right-hand side also, there's a papillary muscle extension that crosses part of the VSD. And again, it would have been difficult to know that just by viewing it in the operating room. But with using subendocardialization, we were able to get this closed as well. This is a very interesting case of a patient that was sent to us from outside who had had multiple attempts of closure of apical muscular VSDs with devices. And I'm not sure if the video is going to work. Can you guys get that video to work on the right? Just click on it. Okay, so maybe this will run. So with these virtual images, what we were able to do is the cath people were able to tell once it rotates, you'll see that there were multiple devices in the mid and apical muscular septum, but there were residual holes inferiorly and medially to the device. And without this picture, it would have taken a very long time in the cath lab if they could do it. But with that information, they were very quickly able to find the hole and close the residual VSD. And that's a picture of it. It's a cath, but we won't try to make it work. It basically shows on that picture that all the VSDs are closed. And this is a model of a baby with double outlet right ventricle. On the left is a segmented image, in the middle the virtual model, and on the right the real model. And this is a patient where we were able to tell from the real model that there was going to be difficulties getting that VSD to the aorta. In fact, in one further image up more anteriorly, I was able to tell that the tricuspid valve was going to be involved, and so we had to alter our plans. Here's another double outlet right ventricle patient, and you can see on the left-hand side that the VSD is a bit remote but committed to both great vessels. But from the image here, we're able to decide that the pathway to the aorta would be much more complex than the pathway to the pulmonary valve, and so the VSD was closed and a switch was done. And this is that same patient with us being able to hold it in our hands, and you can see that you can actually we can make multiple models of this, and we can cut them apart from different vantage points, and you can actually get a very good idea what you're going to need to do in the operating room. This is the last patient, a very interesting patient that was cared for in the cath lab. This was an older patient who came to us after having a Glenn and Fontan procedure and was having recurrent strokes. And what we found on imaging was that there was a pseudoaneurysm from the right ventricular infundibulum through which he was throwing clots. The vessels were virtually occluded. The other approaches to this were going to be very difficult, and so we thought about doing a transthoracic approach, but we didn't want to dislodge the thrombi or create a problem with the actual structures in the heart. And so given the 3D imaging that we're able to generate, we're able to use sternal wires and the IMA as landmarks, and we're able to puncture transthoracically into this pseudoaneurysm, go through the pseudoaneurysm, place an amplatzer device, and then fill the rest of it with coils, and then back out through the wound in the chest wall, and this went very well. As you can see, this would be a very difficult surgical case to do, and we really didn't have any other access to do it in the cath lab. So, this is all great for very complex patients, but I think that one of the take-home messages should be that we don't need to use it for everyone because it is very expensive, and we heard some of that this morning. So in some of the studies that have now been looking at meta-analysis and multi-institutional studies, it's come across, and this is just only one of them, that it is very useful, but it doesn't need to be used except in the most complex of situations when the cath person or the surgeon cannot get a good 3D image of what's going on in the heart. So in closing, I'll just say that 3D heart models offer better understanding, especially in double outlet right ventricle and complex multiple VSDs, and help for surgical planning. Its potential can help to reduce intraoperative times, increase the success of interventions, and hopefully lower the risk of complications. Thank you very much for listening.
Thank you, Dr. Mosca. I have a small question. How effective, how cost effective is this one, the modeling? How cost effective? How cost effective?
Cost effective is really, it's really a loaded term, right? So for each patient that we utilized it on, I would say it helped a lot. But in terms of actually how it helped, reducing operative times, reducing complications, it's hard to know, right? So I can tell you one thing, it should not be used across the spectrum because it is very costly. So we don't do that. In fact, even in New York City, where we have lots of money to waste, as you showed in the beginning, we couldn't afford it. We had to get a donor to supply money so that we could buy the equipment.
Okay. Okay.
We did some of these. The problem that I faced is, okay, you get a good 3D visualization of the problem, but when we are having the flaccid heart, sometimes it doesn't translate to what we see in the image or generated the model. But when we actually go in, because the heart is flaccid, it can not exactly, it doesn't look sometimes that way.
Well, I think what he was saying is that you have a solid image, and then when you go in the operating room and you arrest the heart and the heart is flaccid, it doesn't look quite the same.
Yeah.
That's very true, but it also doesn't look the same when you do that without that knowledge.
Yeah.
So I think really it's just another tool to give you 3D spatial imaging so that when you get in there with a double outlet right ventricle and you know there are two pathways and now the heart's collapsed, you even have less information if you don't know about it beforehand. That's the way I look at it.
I was thinking that we could measure things in advance and put it, but it becomes very big. We thought we could measure and
Right.
do everything in advance, and we tried doing it. But then when you go in, you are a little worried about whether what you predicted there and is it translated down.
Absolutely, but again, you have to use your experience with that information. The next step, I think, really is to do the repairs mathematically, and that is to take those models, create the tunnels with a computer, put flow through them, and then see what you come up with, gradients, stuff like that.
I enjoyed your talk. We've been using this technology for essentially positioning and looking whether the chest can be closed in smaller children who need a VAD, HeartMate 3 or an HVAD. Sometimes the patient size is such that you're worried whether after you put it in, you'll be able to close the chest. What would be the ideal location for the inflow cannula, for instance? So we use it as a virtual reality with goggles in an IIT lab, and I find that pretty useful.
Another good use, yes.
I have another question. Basically, what you are showing is surface 3D remodeling, right?
Well, there's surface 3D modeling, and then create a model with the printer.
Right. Now, on the operating table, what you are going to have is limited incision. Like you are going to look at the VSD which you showed through the right atrium, and that probably is not yet ready for the modeling. Am I right?
It's looking through the right atrium is not ready for.
You will make an incision on the right atrium,
Right, through the
and then you will retract the tricuspid valve, and then you will look at the apex of the heart to see that VSD.
Right.
But on your 3D model, what you are going to actually see is a cut section, and at the base of that, you're going to. So the perspective is not actually what you see on the table.
However, you can take the model that's you generated. Once you have the software done and the print, the cheapest part is actually making the model. The software, the equipment is very expensive, but you can make the models, it's just plastic. And so what we do is we make a whole heart, right? So that we can open the right atrium and look inside because it's hollow, so I can get the perspective like I would be in the operating room, and then transect the heart anywhere you want and look at the actual anatomy of the septum, of the outflow tracts, and then with those two, you can figure it out. But you're right, it's not the same thing as being in the operating room, but I think the surgeons would agree that the reason echo and MRI and CT have helped us in the past is because we didn't have to fumble around trying to figure that out then. This is just another tool for more complex patients.
Is it based only on CT and MRI, or
You can
are
do
we
it-
coming in with ultrasound?
You can
I
do
mean,
it with echo now. We
echo now.
haven't gotten to that stage yet, but it's a different program. It's more money, more time too, because CT imaging, right? You can do that. Echo, it's going to take a long time to get all those images.
Right. Due to want of time, sir has one question. We'll take the last one.
Good catch.
Okay, I enjoyed your talk, Ralph.
Thank you.
I had one question, and I had the impression, that, and I don't know if you agree with me, that if you have a 3D model, there are higher chances that you'll back out of a bioventricular repair than if you were to. So have you just had patients in whom you saw the model and you thought you would not be able to do a bioventricle based on the model, on the solid model, but you go inside and you find that you actually can do a bioventricular repair? I mean, you understand my question?
Yeah.
It kind of dissuades you from going ahead with a bioventricle if you were to go blindly and just connect the SVC, IVC together without looking inside.
I understand what you're saying. Instead of using it as a positive, could it deter you from doing something that you should have done?
Absolutely.
And I suppose that's absolutely possible. I haven't had that happen to me yet. And you guys, and as I've seen through the meeting, do a lot more older, complex biventricular repairs than we actually do in the United States, I think, because of the way the patients present to you. But I haven't had that happen to me, only the opposite, but it certainly could. And for me, it's only been additive information. The patient with the double outlet right ventricle with the septum, I was really thinking about trying to resect that septum and making a baffle, and from that model, it changed my mind immediately. The pulmonary valve is fine, the VSD could be closed straight down, it should be no problem. I only gave you one image, but it was a very serpiginous VSD, and so that made it look obvious, whereas the other imaging made it look much more difficult. So I haven't had that happen, but I'll keep that in mind now that you reminded me.
Thank you.
We will welcome the next speaker.
Thank
That
you.
is Dr. K.R. Balakrishnan, Director of Cardiac Sciences, Chief Cardiothoracic Surgeon of Fortis Mallar Hospital, Adia, Chennai. Welcome, sir. Innovation to reduce the cost of therapy.
Thank you very much. Okay.
Is problem in the AV or the visual?
Okay.
the display, so 10 minutes it will take. I'll just announce.
Okay.
So we humbly apologize for the delay. Since there is a technical problem, we need to reboot the whole audiovisual system. So it will take 10 minutes. So if people can avail this as a break, it will be beneficial. Thank you. I mean, we apologize humbly for this delay in the presentation and discontinuity.
I think we'll come back after 10 minutes.
10 minutes of break, please. Thank you. Okay, your attention please. Meanwhile, in this break, we would like to give you some instructions regarding the fetal rhythm workshop. So as Dr. Sejal Madam will be the chief moderator for this workshop session, and she has requested whoever is interested to take part and complete the session, we would like to be joining the workshops right from the beginning. Since the workshop begins with a pre-module quiz, knowing the background knowledge before the workshop is begun, and then the workbook will be distributed to all the participants. So try to be, whoever is interested, please occupy the middle rows right now. I mean, whenever the opportunity comes, because we have got another 3 lectures to go on in this session. And once the workbook as well as the pre-module quiz is given, there will be 10 minutes given for the pre-module quiz. After that, the lectures will be started, and then the exercise book will be performed as the third lecture by Dr. Sejal Shah Madam. And following that, the irregular rhythm sessions will be followed. Right at the end of the workshop, there will be a post-module quiz. So following the post-module quiz, there will be a rewards announced for the first place and the second place. And the first row will be occupied by all the speakers who will be conducting the workshop. And since this is a day-long workshop, and it's a new concept to monitor the rhythm in fetos. So that's why I think whoever is enthusiastic should be taking part actively in this session, and please occupy the middle rows. I'm requesting once again. So, right, I mean, in few moments we'll be getting away with the glitch that we are having in our the audiovisual. So please bear with us.
అక్కడ వర్క్ అవుతుంది, ఓన్లీ సెంట్రల్ రావట్లేదు. స్విచర్ దగ్గర ఒకసారి కనెక్షన్ చెక్ చేయి. కెమెరా కూడా రావట్లేదు కదా స్విచర్ దగ్గర.
కెమెరా చెయ్యి, నేను మారుస్తాను వేరేది.
రావట్లేదు, తీసుకోవట్లేదు.
కెమెరా
Don't change. Only the central one.
ಅಲ್ಲೇ ಕುಂಡ್ರೆ ಅಂಚೇನೆ ಇಲ್ಲ, ಏನು ಹಿಂದೆ ಕುಂಡ್ರೆ ಓಡ್ಕೊತ ಬರ್ತೀವಿ. ಇಲ್ಲ ಈ ಸರ್ ಅದಾರು ಈ ಸರ್ ಬೇಕಾ ಇಲ್ಲೇ ಹಿಂದೆ ಕೇಳ್ಕೊಳ್ಳಿ ಓಡಿದ ಅಷ್ಟೇ.
So on behalf of the organizing committee, we are extremely sorry that the main screen is right now still giving us a problem. Just to keep the time ticking and keep the talks going on, our side screens are working. The display and the slides will be going on in the side screens. So for the time being, we will continue with our talks of the previous session, which was left with Dr. Balakrishnan sir. And I request humbly for all the persons to please occupy the sides so that the side screen slides can be seen and we can continue the session. We are extremely sorry for this. We apologize. However, we wish that once by the end of this session, we'll be able to fix the main screen glitch that is happening. Please bear with us. So, can I call upon Dr. Balakrishna sir, please, sir.
We have one outside. All of them are sitting outside.
So again, I would request if your friends are outside that we are starting with the session. Same thing can be conveyed to the persons who are outside. We'll make arrangements to call them also inside. Please.
Dr. Balakrishnan, Director, Cardiac Sciences, Chief Cardiac Thoracic Surgeon of Fortis Mallar Hospital, Adyar, Chennai.
I can't see there. All right, okay. Can you start? Good morning. Thank you very much. I've been asked to speak on innovation to reduce the cost of therapy over the next 10 minutes. When I first got this invitation, I didn't quite know how to structure this talk. Give it my shot. All of us are very much aware of the challenges in healthcare delivery in this country. Everyone expects first world results at impossibly low levels of funding. India imports the majority of its medical equipment are imported. It's chronically underfunded, less than 5% of its GDP on health overall. The government spending is less than 1.5%. Insurance penetration is poor, coverage is grossly insufficient, no dynamic mechanism to keep pace with medical advances. And thanks to Dr. Google, every patient's expectations are astronomically high. Only 2% pay income tax, and yet everyone expects and needs high-quality health care for free. The existing government's insurance schemes, which were started about 10 years ago, do not take into consideration risk categorization. There are standard fixed packages for every procedure, leads to selection bias against sicker patients. Compare this with Brazil, which is a BRIC country, 9% GDP on healthcare, and they import much less than we do of their, because they have a very vibrant device industry. I'll come to that later. I thought I needed to use an example. I'll take an example of heart transplant because it's expensive, it's high-tech, it involves a whole lot of issues, and at the same time, how to bring it into the affordable domain. I'll use that as an example. It's expensive. The average package is around 25, sometimes 30 lakhs, which is around $50,000. State support is minimal or negligible. In our state, for poor patients, we get a 15 lakh, which is around $20,000 reimbursement. We have to, the outcomes are monitored by the state authorities, so the expected one is survival 90%. There's no reimbursement for organ transport, pre-op VADs or organ affordable. So we need affordable VADs, we need money for biopsies, we need money for transporting organs, we need, why does it keep It's not playing here as well.
It's not working.
So there are two types of innovation. One is procedural innovation, the other is product innovation. I shall cover both. So we needed to have 30% of patients die while they're waiting for an organ. So we needed an affordable bridging strategy. HeartMate 2, 3, and HVAD in this country are essentially used as destination therapy because they cost upwards of $150,000. So it can't be used as a bridge to transplant. CentriMag is supplied at $6,000, around 4.5 lakhs to the hospitals who add to the hospital costs. So we started using the Rotoflow pump, which is the pump used for ECMO. That's supplied at 12,000 rupees, $150. Is one-third the cost of an intra-aortic balloon pump. The trick was to make it usable as a VAD. I'll show a very brief video. Is it playing? It's not playing here. Gosh, I can't see it. Is it playing? Can we have the video on, please? Why it's not playing? No. Okay. So we do all these bad implants off pump. We don't use a heart-lung machine. If you lay the patient straight, there's no hemodynamic instability. We stitch a graft onto a Teflon felt. There are surgeons in the audience who might find it useful. The ventricular function is poor, so it's easy to take sutures. And since there is no displacement, hemodynamics are rock stable. You don't need anything. If you read it from a sternotomy, to displace a dilated ventricle back into the main wound, you'll have instability. We make a very small upper sternotomy incision going to the third space and expose the aorta. And even in a re-op, it's easy to do this. Then we tunnel in a graft from the right fourth space so that we don't invade the mediastinum, so making a re-entry for a future transplant easy. And this is pretty straightforward stitching. We don't reuse anything at all. Everything is new, despite which the cost can be kept very low. It's a good idea to use a aortic punch to excise bits of aortic wall so that the anastomosis is wide. And then a standard anastomosis is done. And all this is done with just 1 milligram of heparin, no bypass, so that even in a sick patient, the bleeding is very little, so you don't need to transfuse. So we stitch in this piece of graft extended from over a Teflon donut and thread those sutures. And then we use standard venous cannulae. And you make a small stab in the ventricle, and you on the basis of echocardiogram, you predetermine the length to which the cannula are inserted. Then you make a hole, and they enlarge them with Hagar dilator, and then you push this cannula in. And you can then tie the, as you can see, there's virtually no blood loss off-pump VAD implant. And the cost of the VAD is $12,000, so the whole procedure, including the operating room, can be done for 100,000 rupees or something. It's substantially cheaper than doing a VAD. A CentriMag in our hospital will cost close to 10 lakhs. So, and we have supported a patient up to 4 months with it. So to mobilize a patient, we use a hardware bag and put this pump inside it. So this is a procedure innovation. It works for us, as I said. Substantially lower cost with pretty much the same outcome. The next challenge was endomyocardial biopsies. You need several biopsies over the course of the treatment. It's not funded. In Fortis hospitals, the biopsome is supplied at $38,000. They add 30% surcharge. Each EM biopsy costs $85,000 in our hospital. So we started using bronchial biopsy forceps. They are 3,000 rupees. I don't even know why the cost is so much less. The jaw of the bronchial biopsy, in fact, is bigger, so you get a bit. We've done over 150 biopsies without any incident. And as I said, since it's 5 French, or even smaller because it has to go through a bronchial, the thing in a bronchoscope, it gives very good biopsy samples, as a matter of fact. I don't know what the legal requirements for this are, but that's what we've been using, and quite successfully at that. The third was organ transport was huge. In the majority of patients are self-paying. There's very little insurance coverage for organ transport. Donor hearts are now available across the country, but private jets are expensive. and they're not paid for by anybody. Sometimes when you use a private jet and land in the donor hospital, the donor is dead or sick, and who pays for it then? So we started using commercial aircrafts, and we put in place a logistics team. We looked at classified airports according to type 1, 2, 3, and 4. Then the assessment of the donor organ is done by a trained cardiac anesthesiologist. We take into consideration the donor and the recipient status. We monitor the status of the flight in real time to decide on the time of both donor cardiectomy and recipient preparation. It goes through the usual security check. When we first started, the size of the box was not standardized, so and a couple of times we had to, it wouldn't go through the security box, so we had to take it out and show that it was a donor organ rather than, you had to do what it took. We have to buy a separate ticket, so it's next, not in the overhead cabin. And we looked at a study comparing commercial aircrafts, 116 transplants. We compared commercial airlines versus a private jet. The data was comparable in terms of ischemic time, distance travel. The cost was 10 times less. $3,400 was $27,000, so it's 10 times less expensive. No organ, impressively, in a country of this complexity, no organ was discarded because of transport issues, pilot not able to land, flight canceled, and no patient had graft dysfunction required mechanical circulatory support. So this we presented and published in April of this year in the ISHL meeting in Orlando. The longest distance travel was 6.5 hours ischemic time. And the outcomes have been good. Overall transplant outcomes of 76% 5-year survival. Pediatric transplants of 110, we have a 5-year survival close to 82%. So it's possible to get reasonable outcomes despite cutting cost. The third major project we undertook was to develop an affordable LVAD for our population. The existing realities are cost is upwards of 100,000. Battery controller, spare controller are all thrown away if a patient gets a transplant in a few months. And only in India does a patient who gets a transplant wants a refund for the battery and controller which is not being used. In no other country, when we approached, they had even heard of it. When we approached Abbott and Medtronic, they said this question has not been asked to us in any country in the world except your country. We are great. So it's a waste of money, it's electronic waste. Majority of VADs are used as a bridge to transplant. In this country, the waiting time is never more than 6 months. Even in the United States, the waiting time is never more than 2 years. So why are we paying for a VAD which is built to last 15 years if you're going to use it for 2 years? So that was a question I asked. Working with a couple of Australian engineers who made the HVAD pump, we developed this concept that we would build a pump which lasts for 180 days, and a pump exchange is easy if required to be supported for longer periods of time. We needed a device that will allow patients to be discharged home and to be used as a pediatric device. Today, even Centrimag or even Berlin Heart cannot be discharged home. They have to be in the hospital. So we built this pump using a polyurethane housing where the pump and the controller are outside the body. They're going to be used for a period of 6 months to 8 months as a bridge to transplant, but you can go home. And with the titanium housing if you want to be a completely implantable pump with the design goals. And as you can see, the pump and with an integrated controller is a pretty small piece here. I hope it works here. And then the pump driver is very small. It's the size of your mobile batteries that we use for a mobile phone with an iPad as the system monitor. We also have a design for a BioVAD. Pediatric patients, a lot of them are biventricular restrictive cardiomyopathy. VADs don't work, as we know. The SynCardia now is for adults, 50 and 70 kilograms, so a lot of children are outside the purview of BioVADs. So we looked at a continuous flow BioVAD with a very clever mechanism where a single repulsive drive mechanism can integrate adult and a pediatric VAD. Pediatric VAD is used for the right RVAD support and the adult for the left support. And we have an Australian, American, and a US patent for this. But it's one thing to have an animal work up to the stage, but how easy it is to bring it to the marketplace? What are the challenges for product innovation? Animal testing in this country is virtually impossible. No clarity on how many are needed to be treated in animals, for how long before human trials can be started, how many human implants are needed before approval for commercialization, funding from DBT and DST is impossible for private hospitals. I've had several meetings with the chairman of DST. He says, you're from a private hospital, we can't even look at you. Recent press release, Indian regulation treats devices and drugs and pharmaceuticals together. There is virtually no imagination in this. There's no clarity at all. We developed an implantable pulsatile pump 4 years ago. This ventricle is part of a device called PulseCat from Germany, which is used. So the ventricle is available for $100. So I took a Y connector and implant and put in a TTK Chitra valve as mitral and aortic as a Y connector, and actuated by an intra-aortic balloon pump. So you could really have a pulsatile VAD, which can cost less than 1 lakh. So this is in a sheep model in an animal. Works very well. It's impossible, it's easier and cheaper to do an animal trial in Lvad in Belgium or in Sydney because, as I said, getting permission in this country is impossible. For a CE mark, the rules are very clear because 6 sheep need to survive for 3 months. You get an automatic approval for first-in-man implant. The cost is 36,000 euros, including the cost of a pathologist to do the autopsy. That's the kind of policy clarity we need in this country for device innovation. It's nobody's case that we don't have clever engineers or clever people in this country. They are all over the place. But the policy matters are very, very disappointing, to say the least. So what needs to be done? So we have 2 products. We don't know how to bring it into the market because we're stuck. You go to the health ministry in Delhi, sorry to say, you spend months going from one ministry to the other. Nobody knows whose permission is needed. So what needs to be done? Slogans like Make in India are not enough. They are just slogans. We need clear-cut guidelines, more clarity on animal implants. I think animal implants should be made easier. We have biryani shops everywhere. We have halal meat. Why the hell is it not possible to put it under humane conditions? A VAD for testing into an animal, I can't understand. We need clarity on how many animals need to survive for how long before first in man, how many clinical trials. Federal government funding needs to be based on project merit, not on public or private institutions. Academia industry interaction is poor in India, and that needs to change. Can this happen in my lifetime? I doubt it. Thank you very much.
Thank you, sir, for that enlightening talk. I'd like to call upon Mr. Marco Pozzi. Mr. Marco Pozzi from the Department of Telemedicine, Director of Pediatric Cardiac Surgery, Children's Hospital of Ancona, Italy.
Okay, good morning to everyone. The situation in Italy, but I think more or less everywhere in Europe, is becoming quite difficult to handle. The expectation on the standard of care are raising all the time, and no one wants to wait any length of time. So high quality, no waiting time. And at the same time, the budget for healthcare is at the best frozen, but quite often is actually reduced. So it's becoming really almost impossible to kind of match the 2 requirements, keeping the budget at the same level and reducing, and maintaining a high standard of care with no waiting list. We think that the issue is actually getting worse with time, and I think that is unsustainable within the present organization of the healthcare. Hence, I believe that one should be a bit more creative and find some new solutions. Telemedicine, I think, could be a possibility of finding new solutions. Telemedicine comes to the attention of technology as a consequence of the need to bring healthcare over huge distances. And in this was NASA that require this development to support the astronaut in the space. But soon afterward, has been implemented in normal life. And indeed, the places where it's been mainly used are the places where there is a sparse population with big distances. And Mongolia has been one of the first and is a very good example. Few people, thousands and thousands of kilometers of distances between villages and main cities. And they had the problem of very high birth mortality. And so the issue was to be able to recognize pregnancies at risk as compared to normal pregnancies. And as it was impossible to do everything by bringing the patient to a central hospital, they decided to create some peripheral stations, like the one you see, where we have echo and there is a video connection with a hospital. And doctor are actually instructing the lady or some member of the family to perform an echo, which is probably enough to give them some information to decide whether or not the situation is a risk and need a aircraft transport to a major center, or whether is a situation where the delivery can be performed on site. And with this technology, they dramatically reduce death during delivery. The important thing at the moment is that technology is really developed substantially, and there is no concern if one wants to do any form of development telemedicine, whether or not technology can assist. Technology is already either there or can be developed very, very easily. So teleconsultation is becoming an increasing way of dealing with different situations. Now, we in our department are working on this project, and there are different types of teleconsultation. The first one we started with was hospital to hospital. We are a third level hospital, and we are supporting more peripheral hospitals where they have less experience and they need some support. Now, what you probably see here is this is our station in our department. These are two of our cardiologists, one of which is here, and this is a gynecologist in a different region. She is actually doing a fetal echocardiogram, and what she sees on her monitor is the same thing that our cardiologists see in her monitor, and they actually guiding the colleague in this hospital, telling her or him how to move a probe in order to acquire better images, how to set up the machine, how to interpret the pictures. And it is all done at any distance. The distance is no matter anymore. And so we can have most experience level delivered in any place in the country or outside the country. And in some situation, we even been able to speak directly to the patient when there was a major issue and there was a need for some immediate counseling. This is a similar situation, again, a hospital in a different region compared to ours, a neonatological department. The neonatologists are very good in this department and they're quite skillful to do echocardiograms. But when they find some rare form of congenital heart defect, then they need the support of our cardiologists to make the correct diagnosis. From then, we started thinking that we should support also more peripheral situation. Now, there are little hospital or healthcare facility distributed in the country. And this is some of the tests that we've done going in places in the mountains far away from any hospital. We brought a transportable echocardiogram, ECG, and a machine for telecommunication. And with that, again, our cardiologists in the hospital have been able to guide, literally guide the hand of the either the local doctor or sometimes even people from the ambulance service to do a evaluation of the heart, which has been good enough to decide whether or not there is a heart problem, whether it is a significant heart problem, whether it needs to be transferred immediately. And so it's been really quite a good improvement in the healthcare provided. Another system which I think probably is certainly developed more in other countries, I think here we are in the United Kingdom, it's the use of this type of equipment for telecommunication in the ambulance. So they can give you possibility of doing an evaluation anywhere in the country, and it's very useful for stroke programs, infarct programs, so that if you are in a location where you cannot reach a hospital within 20 minutes, half an hour, you can set up a pharmacological treatment for dilution of clot, both in cerebral or myocardial situations. We have seen a progressive use also in fields like psychiatry, which at the moment seem to be the second most used field for telemedicine. And despite the fact that I was a bit surprised because I thought the human contact was important, it seemed to be very much appreciated both by the doctors and by the patient, this type of communications. And there is really a large number of papers that report that both in terms of reliability, clinical outcomes, of course, cost, and doctor and patient satisfaction, the telemedicine type of consultation seems to score better than a direct physical in front of one of the other type of examination. Other fields like ENT is also been a field where telemedicine has given a good contribution. And indeed, in GP practices now, with simple equipment, GP can do a evaluation with the backup of an ENT doctor in hospital, and as a consequence, they can really bring the service to the patient and reduce a bit the load of work from major hospital. But the other situation where I think there is a great advantage is in A&E. What has happened in our country is that there were a lot of small hospitals in the territory, and a lot of them have really been kind of emptied. I mean, all the clinical and surgical specialties have been removed, and there is only some kind of A&E department. And people would still go there because that's the only hospital they have near where they live. But a lot of time they are not equipped, neither in terms of human resource nor in terms of equipment. So the issue is this, so anyone with any problem can end up in one of these E&E department, need in some cases a specialist opinion, and with the use of a robot, which is just an equipment to put yourself in connection with everyone, can be connected to the control station of one of the major hospitals, and from the control station can be put in contact with the specific specialist that is needed in the occasion, and the specialist can decide whether or not some form of treatment can be given where the patient is, or whether the patient needs treatment, immediate treatment, helicopter treatment, and so on. And another feature which I think is very valuable is the possibility of actually having the connection on your telephone or on your iPad or computer. So wherever you are, you can actually see the patient, see all the parameters of the patient, and instead of being on call and having a telephone call and then someone describing you a situation, you can actually be able to see the patient zoom in, but the central and the picture on the right, it's the central one is what you normally see looking at the patient, and the one on the right is zooming in, which you do yourself, and you go and have a look at whatever you want. So I think it's certainly an improvement compared to what we have now. And the last area where I think there will be a lot of use, probably the largest one, is the possibility of following patients at home. So all the chronic diseases, old people that very often in our places tend to fill up hospital use beds for months, and being away from the family and a familiar situation, with this system can actually be monitored at home. This is an example of a system already in use. The patient is given some equipment to measure blood pressure, ECG, weight, and different type of parameters according to the particular type of pathology. So what the patient is saying is that he can actually have a daily check, and he can communicate with a doctor once or twice a week through this type of connection, and he feels that he has the same form of assistance as he has in the hospital, but he feels he's more in control because he knows what's happening. And indeed, with this system, we've been able to discharge patients earlier, avoid a lot of recovery, and as I said, we've been able to leave patient at home with the family for months and months in situation in which we would otherwise had to admit the patient. And there is also another side of this type of technology, and is the fact that this not only the patient can be kept in a comfortable situation, but doctors can be at home and do a consultation, evaluation of X-ray or any type of investigation. So that can create a flexible working environment, which I think could be beneficial for everyone. But for example, we have big problems with I mean, normal life problem with pregnancies, because any lead doctor will get pregnant, it almost immediately, and with that I mean second to third maximum month of pregnancy, would stop working, and they won't come back working until about 8 months to a year after delivery. So it's a big loss of manpower from a certain point of view. And the only issue is that they do not have direct physical contact with patient. Now that is a loss of manpower, and is also a loss of opportunity for ladies, because in many specialties, and surgery certainly is one of them, if you are kept away from your work for a year or even longer, it's always more difficult to come back and to keep up the pace of progression with other colleagues. So with this way, you can actually follow your work and keep working, as I said, in a much more homey environment, and I think can give a lot of benefit, reducing traveling time, and on and on. So one of the major concerns is the cost of setting up telemedicine. I personally think that it's like when we were using typing machine and the first computer came out and people were laughing because we're saying we're never going to use them, they're so expensive and they do so little more than our machine is doing. And nowadays I think no one would ever consider going back to a typing machine. So the technology would have some cost, but overall I think with all the consideration we've done so far, I think will be certainly the only way I can imagine to keep up standards of care and contain cost. So the conclusion is this: in my mind, the question is not why telemedicine, but at this stage, why not? Thank you.
Thank you, Dr. Kosi, for the enlightening talk.